The meeting has started.
This next slide, please. As we know that in the past few years, robust data from a lot of clinical trials have demonstrated that proper guidance of transcatheter interventional therapy in acute coronary syndrome, chronic coronary syndromes, and peripheral artery disease has become an essential for interventional cardiologists. And intravascular imaging technologies, including IVUS, OCT, infra-red thermal, and so forth, complemented with coronary CT angiography and FFR estimation, make precision in full and effective revascularization in elective as well as in acute setting, such as STEMI, non-STEMI, left main or complex bifurcation, CTO, multivessel CCS, calcified coronary vessels, as well as peripheral artery disease with critical length ischemia. So comprehensive review and first-hand experience sharing will be presented in the present web-based conference by 6 prominent experts. The goal is to help perfect emergency and elective coronary and peripheral artery revascularization in daily practice. So stay with us until this webinar finishes. And also, please feel free to actively participate in discussion via chat box. And next slide, please. It is important to note that the content of this webinar is copyrighted by the APSC and should not be distributed without the prior permission of the APSC. And the views and opinions expressed in the webinar are those the faculty members and do not necessarily represent those of the APSC. I think I can proceed to invite our first speaker. Please, next slide. Okay, so Dr. Eric Oliver Desaison will be talking about intravascular imaging guidance in urgent PCI management of acute STEMI and non-STEMI with or without FFR check. Please, Dr. Eric.
Hello, good morning. Let me just share my screen. Sorry. Sorry. Okay, I hope you can see my screen. Thank you for this invitation to talk about this topic. For my lecture, I'll be talking about the use of intracoronary imaging and FFR in the management, in the percutaneous management of ACS. This is the outline of my lecture. We'll talk about a little on the basic of intracoronary imaging and FFR, and particularly discuss how does this modality affect PCI, particularly in ACS intervention, and look at some of the evidence in terms of its usefulness. And at the end, we'll have a practical application for the use of imaging as well as FFR in the management of ACS. So we know that cardiovascular disease is the leading cause of morbidity and mortality worldwide, and coronary artery disease account for almost half of the cardiovascular death. And percutaneous coronary intervention, in addition to guideline medical therapy, has greatly improved the outcome of patients with cardiovascular disease. In fact, the greatest impact of PCI has been observed in the treatment of ACS. These patients are at the highest risk for adverse cardiovascular events, and they get the most benefit from invasive intervention. Numerous studies have been done to continually improve the outcome for these patients, including the use of various interventional modalities such as imaging as well as cardiovascular physiology. So it has been shown by numerous studies and meta-analysis that an early invasive treatment is beneficial or superior to just conservative therapy in non-STEMI as well as in STEMI. Studies have also shown that complete revascularization by percutaneous coronary intervention is superior to just infarct-related artery PCI in the management of ACS. It has been shown to reduce cardiovascular death, reduce myocardial infarction, as well as unplanned cardiovascular vascularization. So, what is our treatment strategy for ACS, particularly in patients with multivessel disease? So, as I mentioned, for patients with ACS, immediate angiographic assessment is necessary for the assessment of acute chest pain. In the majority of cases, you will see a culprit lesion, which will benefit from immediate recanalization and stenting. However, up to half of patients, particularly with STEMI, will have multivessel disease, and the management of this non-infarct-related artery will have a big impact on the outcome of these patients. In non-STEMI, there is a possibility of multiple culprit lesions or no obvious culprit lesions, wherein the use of intravascular imaging will be very helpful or necessary. Angiography alone may have some challenges in terms of management of patients with ACS. It is important to acknowledge that there are inherent weakness of coronary angiogram to accurately assess the vessel and lumen geometry, and its inability to evaluate the plaque components as well as accurately detect the presence of thrombus. Information which can be more accurately provided by intravascular imaging. Where diagnostic uncertainty exists, particularly in the severity as well as the significance of the lesion, the use of intracoronary imaging or coronary physiology will be helpful. Assessing stent size as well as optimizing the result of PCI will also be aided by intravascular imaging. Now, what are some of the modality that we have? We have intravascular ultrasound. The principle is that it produces sound waves which are reflected by the tissue and produces an electrical image based on the return. The current IVUS systems operate at around 20 to 60 megahertz, and we have already have high definition IVUS systems, which gives us a very clear picture as seen in this graphic. You can see accurately the size of the lumen, and you can characterize the lesion, particularly whether it's calcific, whether it's lipidic plaque, or whether it's fibrous plaque, and this can affect a decision in terms of PCI strategy and management. Optical coherence tomography is a newer modality which uses near infrared light, which is also reflected by the endothelium, and it generates a higher resolution cross-sectional images, and as well as three-dimensional volumetric images of the vessel. The shorter wavelength of the infrared light produces higher resolution. However, it has lower penetration depth, and it's very, very useful in terms of the detailed assessment of the vessel wall, the thrombus, as well as the expansion of the stents. These are just a comparison of IVUS versus OCT. So the IVUS, the advantage is that we have a lot of clinical experience in it. We can easily use it. without pre-dilatation, and it allows us to accurately measure the true vessel size. It also has some predictors in terms of stenosis or outcome of PCI. The disadvantage is that sometimes the image can be difficult to interpret and needs some additional training. Tissue characterization or thrombus dissection may also be a bit challenging, and as well as viewing of the stent apposition. The OCT, the main advantage is the 10 times higher resolution compared to IVUS. So you have better tissue characterization as well as thrombus detection. The image is a lot clearer and easier to interpret, and you're able to really see clearly the stent. However, the disadvantage is that it requires additional contrast to produce a good picture, and needing flashing to clear the lumen, and sometimes will need pre-dilatation for you to be able to do this. So in ACS, the most common pathophysiology is plaque rupture, triggering the formation of intracoronary thrombus. And this is very well visualized by intravascular imaging. So imaging is useful in ACS, particularly when the infarct-related lesion may be non-occlusive or it is indeterminate. As seen in this picture, you have some haziness in your coronary angiogram, but using intravascular ultrasound, you're really able to see that there really is a thrombus that is occluding the lumen of the vessel. So imaging guidance can provide additional lesion information to guide the treatment. And intracoronary imaging has increased the awareness of other causes, non-atherosclerotic cause of ACS, as we shall see later on. So these are some of the common pictures and use of intravascular imaging. You can very clearly see the culprit lesion. In this case, the coronary angiogram shows a lesion in the left anterior descending artery. And you're able to see by intravascular imaging the plaque rupture, which shows discontinuity of the endothelium, as well as the cavity at the lower portion, which contains the lipidic plaque, which caused this ACS. Plaque erosion can also be seen by intravascular imaging. This consists of fibrin deposition over the lesion. It is less typical in clinical presentation for ACS, but it is useful to recognize, particularly using OCT, because treatment may be tailored in patients with plaque erosion where there is no where there is no clear plaque rupture, and with good flow, it is possible to probably treat them medically instead of putting in a stent. Another less frequently observed but important finding by intravascular ultrasound is an eruptive calcific nodule. You can see it as a discrete calcium nodule with plaque disruption, and this can cause significant challenge when you deploy your stent and when you try to optimize it. But by being able to detect it with intravascular imaging, you're able to decide whether you will need additional modalities such as rotablation to be able to properly prepare the lesion and adequately stent these lesions. Intravascular imaging also enables the diagnosis of non-atherosclerotic cause of ACS, which would otherwise be very difficult to ascertain just by angiography. Remember that the angiogram only is a luminogram and does not adequately assess the vessel wall as well as the other deeper structure. Some examples of this will be external compression, which we see in the panel 5. In the angiogram, you just see a lesion or stenosis in the ostial left main, but looking at the intravascular ultrasound image, you're able to see that there is no disease in the endothelium, but there is external compression. Another example is in panel 2, where you see coronary artery aneurysm, which also can present with ACS. You may sometimes miss this during the angiogram and think that there is no significant stenosis, but there might be complex lesions hiding inside that aneurysmal dilatation. Other cause like coronary artery spasm is very well seen using intravascular ultrasound, and you will see that there is no significant atherosclerotic plaque on the intravascular ultrasound, and it was just a spasm which was relieved by administration of nitrates. This angiogram shows multiple filling defects causing obstruction. Intravascular imaging provided further clarification, and it showed that after thrombectomy, there is no underlying plaque rupture, and it was just an embolism coming from a different source. Thus, this patient was just treated with antiplatelet and anticoagulation and did not need stenting. Another common cause of ACS, particularly in younger to middle-aged female, is spontaneous coronary artery dissection, which might be difficult to differentiate from CAD by angiography alone. Intracoronary imaging can identify the presence of the false hematoma shown here at the bottom, and usually for these patients, treatment is also conservative. So based on the European Association of Percutaneous Coronary Intervention, these are some of the indications and usefulness of intravascular imaging in ACS, particularly thrombus detection, in identification of the culprit lesion. OCT is probably the gold standard in terms of thrombus detection because of its high resolution. Intravascular imaging also facilitates delineation of underlying plaque etiology, as well as high-risk features which may guide treatment. And when the culprit lesion is not very clear, particularly in non-ST ACS presentation, intravascular imaging will be very useful. The role of intravascular imaging in characterization of plaque, as has been shown in studies, has been highly predictive of future adverse event. High-risk plaque characteristics can point to higher predisposition to future MACE event. Although there is not yet strong evidence to do PCI in vulnerable plaque, identification of these high-risk plaque characteristics should identify patients who would benefit from increased intensity of risk factor modification and treatment with medical therapy. In left main, in terms of determining the hemodynamic significance of lesion, pressure-derived hemodynamic assessment is the gold standard. However, for left main, which we also see in ACS, sizing using intravascular imaging like IVUS or OCT also have very reliable values. In most of the studies, they have shown that an MLA or minimal lumen area that is greater than 6 millimeters squared in the left main is considered non-ischemic and will not need treatment. MLA, which is less than 4.5, can be considered to be ischemia generating and will need treatment, while those in between will probably benefit from using a non-invasive or an invasive pressure or physiology determination to assess its severity. Aside from determining lesion severity, intravascular imaging is very useful in left main intervention in terms of optimizing the result of PCI. PCI optimization using intravascular imaging is also very useful. Although in non-left main lesions, we don't have a single MLA cutoff by imaging to determine lesion significance. Intravascular imaging is still useful for lesion assessment, for preparation, sizing of the balloon of any stent, and optimization of the stent result. looking at the presence of dissection, for example, the presence of malapposition or the adequacy of stent expansion after deploying the stent can be very well seen using either IVUS or OCT. So these are some of the guides that are being used now. This is for first is for OCT. You can assess the lesion prior by looking at the morphology, particularly the calcification. You can adequately assess the length of the lesion and diameter of the vessel so that you can aid in the planning for the PCI. Then after you deploy the stent, you will have to assess whether the stent is already optimal, looking at medial dissection that needs to be corrected, the apposition of the stent, as well as the expansion of the stent. All of this information can also be seen via IVUS, and these are very useful in making sure that you have good, long-lasting results with PCI. So in general, there has been an increasing trend in the use of intravascular imaging. However, it's still quite low. Only about 8% of all intervention in MI has been guided IVUS assisted based on this registry analysis. And for OCT, it's less than 1%. Although using this database, they have shown that the use of either of this modality has been associated with improved outcome. This is another database where they shown that increasing use, but still underuse of this modality. The low rates may be due to lack of operator familiarity, limited access, the high cost of the catheter. Sometimes it may cause longer procedure time, and the need for contrast, particularly for FFR, and the perceived complication risk. But let us look at the evidence. The ultimate trial was an all-comers trial looking at the use of intravascular imaging, intravascular ultrasound in all comers, and it showed that using IVUS guidance compared to just angiography guidance produces better results in terms of decrease in your outcomes.
You have 2 minutes left.
Okay. Okay, and then same data using particularly in MI, showing that there is better outcome in IVUS guided versus angiography guided. For FFR, the use in determining lesion severity has been validated, particularly in chronic stable angina. There is some fear that it may not be reliable in MI, particularly in infarct-related artery because of abnormal vascular function. But FFR guidance is useful in selecting non-IRA lesion for intervention. So I'll just proceed with the evidence for using FFR also. It has been shown in the FRAME AMI that comparing FFR-guided complete revascularization versus angiographic-guided revascularization resulted in the lower rate of death, MI, and repeat revascularization. So let us just compete. When do we use intravascular imaging in ACS? When there is a clear culprit lesion, we can probably just proceed with PCI of the culprit lesion, unless there is a complexity where an intravascular imaging will be helpful in terms of planning or optimization. If there is ambiguous angiogram, as well as the IRA is not very clear, intracoronary imaging will also be very useful. In non-obstructive or apparently normal angiogram, you can probably use intravascular imaging to find the culprit lesion. For coronary physiology, it's usefully useful in patients with ACS with multivessel disease in deciding whether you need to intervene on the non-IRA lesion. So in conclusion, PCI in ACS is challenging and has worse outcome than stable CAD. And coronary imaging and physiology are underused but can improve outcome in ACS PCI. Intravascular imaging is useful in diagnosis, lesion assessment, procedure planning, and stent optimization. The use of intravascular ultrasound in ACS PCI is associated with superior short-term and long-term outcome compared to angiography alone. And coronary physiology is useful in guiding complete revascularization for non-eye lesions in ACS with multivessel disease. And combining imaging and physiology, when used appropriately, can improve PCI result and clinical outcome. Thank you very much.
Thank you, Dr. Sisan, for a very comprehensive presentation. So I would like to invite all of the panels to give a comment or questions, but I would like to take the first opportunity to ask Dr. Sisan. So if there is any financial constraint, which one you choose in dealing with acute setting, like what you have mentioned earlier on? Imaging, yes, or a functional study?
I think that's a very good question, because particularly in our setting, we really have to choose wisely which one to use. I think for me, when there is in ACS, I find intravascular imaging the more useful and more commonly used modality, because most of the time there will be a relatively clear culprit lesion, which we shall see and need to intervene, and intravascular ultrasound will help us to optimize the result of our PCI. And FFR, I don't commonly use it in ACS, particularly in the infarct-related vessel. Yeah, I may use it for a stage procedure, but most of the time I would probably go for intravascular imaging first.
Thank you, Dr. Sisan. Any other comment from panels? Dr. Lee?
Thank you very much, Dr. Sisan. It's again a pleasure to connect, as always. So I think I fully agree with all that you've mentioned, especially the part where intracoronary physiology and imaging, they are both actually complementary to one another. Well, I just have a question for you. So on the assumption that if you assess a lesion and it appears to be significant, so at the end of the day, you know, personally for me, I'm a believer of function. How about yourself? Do you utilize the functional assessment as the tiebreaker to decide whether this patient should undergo revascularization, or would you use intravascular imaging instead? And amongst these two, what are some of your criteria with regard to selecting lesions that would be amenable for PCI versus lesions that you would probably treat conservatively?
Yes, that's a good question. Thank you for that question. In terms of assessing whether the lesion is hemodynamically significant, definitely coronary physiology has been shown to be useful and reliable, particularly in the non-left main vessels or lesions. Intracoronary imaging can be used in left main lesions where there is already some accepted cutoffs in terms of which is a significant or a non-significant lesion. But outside of the left main, I guess coronary physiology will still be I will still use coronary physiology if the question is whether this lesion is hemodynamically significant or not.
Okay, thank you, Dr. Sisan. I think we should proceed to the second speaker. So I invite my old best friend, Dr. Ahmad Fauziah here, who will talk about coronary imaging guidance in PCI management of calcified coronary vessels, IVUS, OCT, or CCTA. Dr. Fauzi is the chairman of Indonesian Society of Interventional Cardiology. He is a staff of Department of Cardiology and Vascular Medicine in University Pajajaran, Bandung, Indonesia. Please, Dr. Fauzi.
Thank you, Dr. Bambang, for nice introduction. I'm great honor to be invited in this wonderful webinar educational meeting on IPSC. I'm assigned to talk about coronary imaging guidance in PCI, management of calcified coronary vessel, IVUS, OCT, or CCTA. As we know that coronary artery calcification is routinely encountered, yet often underdiagnosed with angiography. You can appreciate here, there is an unexpanded stent. So this kind of moderate severe calcification has been associated with not only this expanded stent, but poor prognosis, a complication and poor prognosis. You can appreciate here the perforations due to the pre-dilatation during calcified vessel management. So it is important to have a comprehensive coronary imaging to guide the proper management of calcified vessel. As we know, there's nowadays in the market, we have intravascular ultrasound and OCT as an invasive intracoronary imaging. IVUS is zone-based imaging. It assigned the calcium by reflected the calcium and hyperechoic with acoustic shadow. And OCT is a light-based imaging. Difference with the sound that can unable to penetrate the calcium. The light can penetrate through calcium crystal, and it has a signal pool region, but we can have a delineate border in this calcium. In CCTA, we had calcified plaque, which signified by Hounsfield unit more than 400. Every coronary imaging has a disadvantage. We know that IVUS, we cannot enable to measure calcium thickness. In OCT, it required blood clearing, and the CTCA, we still have challenging in blooming artifact. The role of coronary imaging in calcified lesion, we can assess how to plan the PCI and assess the procedural risk and assessment of the successful plaque modification. And the last is assessment of PCI optimizations. In the pre-procedural planning, during we can identify of calcification pattern like eccentricity, which is calcified area. We can look at the calcified arc with degree or quadrant. You can see here there is a eccentric calcification, concentric calcification, and calcium ring. And then using imaging, we can measure, we can identify the depth and the superficial calcium, and also we can identify the presence of the calcified nodule. The other identification during using intracoronary imaging, we can measure the thickness, whether there is a thin thickness or very thick calciums. And length is a longitudinal extension, and we can identify whether the calcified in the vessel is a focal or long. Using intracoronary imaging, based on the eccentricity, based on the calcification pattern, we can select the modification device, either using non-atherectomy device or atherectomy device. When we select atherectomy device, what kind of atherectomy device that has a benefit or such a particular calcified lesion. In terms of eccentricity calcium plaque, you can appreciate here, there is a CCTA here, IVUS and OCT. we can look, we can have a eccentric calcification using CCTA and using IVUS, and of course, we can identify the eccentricity using OCT. So the concentric plaque, we can identify this kind of the using of tree of modality. In regard of calcium nodule, which is a convex mass with irregular surface in the intima, using IVUS, we can identify when we see acoustic shadowing by nodular calcification. And then the signal attenuation from the OCT. Look at the signal attenuation here due to the nodular calcification. Of course, both of them we can have a convex mass with irregular surface in the intima. Unfortunately, at this particular lesion, CT angio cannot distinguish calcium nodule and non-nodular calcifications. In regard to calcium length, the three modality can measure the length of the calcium. When you have a OCT, there is a linear demarcations, and when you use IVUS, there is a signal drop here. So you can measure exactly how long is the calcium length. How about the calcium thickness? There is the issue. Either we can measure the calcium is thickness or identify the thickness and the thin calcium using the TRIS modality. The study demonstrated OCT calcium thickness predict crack formation. If you have using OCT, we can measure the thickness of the calcium, and the threshold of calcium thickness for the prediction of crack by balloon dilatation is 0.7. So if you have quite more than this kind of thickness, it is better not to use the balloon, because balloon enable to crack such a calcium, thick calcium. Regarding the IVUS, we cannot measure the thickness of the calcium, but we can estimate the calcium thickness. This study demonstrated when you have a smooth surface and reverberation of IVUS calcium, it means based on OCT, the thickness of the calcium is 0.5. So when you have a IVUS calcium with a smooth and reverberation, smooth surface and reverberation, you can deal with this kind of calcium using balloon dilatation. But if you have an irregular surface without reverberation in IVUS finding, it means that the calcium thickness in more than 1 millimeter. In this situation, we have to prepare using the atherectomy modality. How about the calcific plaque based on CTA? There is no difference were found concerning calcium length and arc, but calcium thickness was overestimated by coronary CTA due to blooming effect. It is important, that's why there is still have some controversy regarding the calcium thickness. Difference between coronary CT and OCT were more pronounced in calcific plaque with higher HU. There is new study by Japanese colleague that demonstrated that the mean density of OCT CCTA finding, which is more than 637 HU of the cross-sectional CT image, predicting the need for rotational atherectomy during PCI. Look at this is the more than 600 from here to here. look at this sensitivity and specificity, very high sensitivity and specificity, which is 93 for sensitivity and specificity for 90. So the positive predictive value is about 80, and the negative predictive value is 97. So it is important to have such information from CCTA during before we are dealing with a calcified lesion. So we can resume that calcium thickness is what the mean density is more than 637, predicting the need for rotational arteriotomy. You should using using atherectomy device when there is a surface irregularity and no reverberation. In the OCT, when we measure the thickness is more than 0.67, it predict calcium crack. Less than 0.67, it predict calcium crack, just using the balloon dilatation. There were calcium score introduced using OCT or using IVUS. If you have these OCT informations, we can predict of the using of modified preparation using atherectomy device if the OCT score is about 3 to 4. But if you are using IVUS, we have to consider using atherectomy device if the score is 2. But CCTA have their own grading system. If you have more quadrant and high density, we should prepare to use in atherectomy device. The other point that have to be considered is the location of the calcified plaque. If the calcified plaque located at the opposite of the side branch, we have to be careful when putting the stent, because the stent can compress the carina in going to compromise the side branch. Look at this study, look at this image, which is the OCT findings show the very thick calcification, and during the stent, it compromised the diagonal. That's why when you have such a situation, it is better to reduce the volume of calcified using atherectomy device. The 3D calcium try to identify the position of the calcium. You can look at this the calcium, the opposite of side branch. So again, CCTA try to play a role in planning of PCI. Using this information, we have to prepare using atherectomy device when we having such a calcified plaque opposite of the side branch. The next assessment is the procedural risk. We have to identify where the wire bias is favorable on non-favorable, especially in the eccentric calcification. Look at this is the favorable wire bias. So, and then this is the unfavorable wire bias because the IVUS attach the healthy vessel here. How about the CT angio? The CT angio is unable to detect, but nowadays, if there is, you can identify the calcium based on the OCT in the inner curvature of the circumflex artery, like circumflex artery or the proximal part of the RCA. It could be, might be there is potentially wire bias. It happened, but if you identify the calcific plaque in the outer external curvature, then we potentially have a risk in rotablade of such situation. So we have to manage it well before rotablate. Of course, after we can confirm using intracoronary imaging. And the other side, the other advantage is we can measure the burr size and longitude. Based on the longitudinal distribution, we can stop where the rota burr platform and when it end. It is important to have assess of this kind of plaque, calcified plaque distribution and the wire bias in calcified lesion before we are using atherectomy device. The third is assessment of successful plaque modification. The key determinant of successful plaque modification of PCI in heavily calcified lesion is calcium fracture and reverberation. Unfortunately, CTCA is unable to assess the successful lesion modification. To assess the PC optimization, of course, we can use IVUS and OCT, but unfortunately, until now, we cannot use the CCTA to assess the optimal result.
You have 3 minutes left.
Okay, I am trying to have some case. This is a 50 years old male. Look at the calcium score, it to more than 2,000, and there is an anterior takeoff. You can appreciate that all the vessels are calcified vessel, and there is an anterior takeoff of the RCA. Look at this is anterior takeoff the RCA. So based on the CTCA imaging, unplugged guiding catheter was select to cannulate the ostium, and then afterward we doing a rotablation after semi-compliant balloon unable to pass. And this is the result of the after rotablation. It is the next case is a very challenging case. This is non-ST elevation, have a history of VT, normal EF, normal LVEF. Look at the ostial LED IVUS, which is a calcified vessel opposite of the side branch. Based on this OCT, based on this IVUS image, we rotablate using 17.5 with speed 150, and we lower the speed to 130 to have a high volume ablation, huge volume ablation. And this is the result, which is confirmed by IVUS, is very good in terms of minimal stent area in the side branch and the ostial LED and the left main. The next is we can identify the eruptive calcium nodule in this STEMI with haziness at distal left main, and we use rotablation and end up with the decay crash. The other is non-ST elevation with haziness. You can see here the favorable wire bias. So we finalize after rotablation with 2 stents were implanted. Then take-home message is using CCTA, we can identify the eccentricity, depth, and thickness and length, but unfortunately, CCTA is quite difficult to quantify the calcium burden and assess calcium modification and stent expansion. Of course, from angio, we can have calcium burden quantification. On the IVUS, almost all we can have this kind of information. In terms of the thickness, we can estimate the thickness by IVUS, and OCT is the perfect tool to identify the calcified plaque. So understanding the pattern of calcification is critical to develop successful PCI strategy. Coronary CT allow for procedural planning, including the assessment of calcification severity, OCT and IVUS are indeed pivotal, not only for procedural planning, but also for procedural risk assessment and fine-tune the need for additional calcium modification intraprocedurally and for guiding final optimization. And the end, multimodality coronary imaging allow the operator to develop the strategy to optimize PCI result. Thank you very much.
Thank you, Dr. Fauzi, for very, very effective presentations. So let me take the opportunity to ask you first. So I can conclude that CCTA is very crucial in terms of the preparation or what modalities you probably need to deal with in the cath lab before the procedure.
Exactly.
But as we know that the patients with chronic kidney disease is quite remarkable, So what is your cutoff point for not sending patients for CT angio?
Yeah, actually the CT we use CTCA for the chronic coronary syndrome, not only for diagnostic but for procedural planning in outpatients as an outpatient. So based on the situation, we can we can refer the patient for CTCA. In kind of CKD patient, I think as long as the kidney function is not really such a acute renal failure, we still have intra CCTA information, because otherwise we are going to have difficult pre-procedural planning, and in the end the outcome of the patient is not good. For CCTA is always become a good modality to prepare the patients.
Okay.
Yeah.
Any other comments from the other panels? Dr. Lee?
I have one question.
Yeah,
can the CT calcium score predict the need for rotablation?
Yes, there is a now we have a there is a grading and classify of the CTCA based on the quadrant of the CTCA and high density of the calcium. The current study from Japan demonstrated if you have more than 600 HU, the possibility of using rotablation should be considered. Of course, we have to look of the arc as well, the quadrant. If there is a 3 quadrant and there are high density, then possibility of using rotablation, it should be considered.
Thank you, Dr. Fauzi. I think we have already, a few minutes behind the schedule. I would like to invite my co-chair, Dr. Lee Zinfin, to give a talk about intravascular imaging guidance in PCI management of left main or complex bifurcation coronary artery disease, damage control plan needed. Please, Dr. Lee.
Okay, thank you very much to my co-chairperson, Dr. Bambang. Good afternoon, everybody. As always, it is a pleasure to connect. So I have actually been tasked over the next 20 minutes or so to speak about imaging guidance in PCI management of left main or complex bifurcation lesions. So I personally wish to start off by putting out a bold statement to state that irrespective of whether this is complex PCI or not, I think in contemporary practice of PCI, intracoronary imaging should actually be routinely used irrespective of the lesion subset. So I hope over the next 20 minutes, I'm able to convince all of you that that is actually the best way moving forward. And without further ado, I wish to now start my presentation. So I've actually divided this presentation into a few different segments. And the first segment is basically a segment to provide all of you supporting evidence as to why intracoronary or intravascular imaging is actually the best form of practice for contemporary management of coronary artery disease. If one assesses guidelines, then the 2018 ESC and EACTS guidelines on myocardial revascularization has actually stated rather clearly that IVUS should actually be considered to assess the severity of unprotected left main stenosis, and this is actually a 2AB recommendation. Well, the evidence supporting the utility of intravascular imaging in the space of left main is compelling. There are lots of data to support the fact that intracoronary imaging, particularly in the form of IVUS, is definitely superior to just performing PCI with angiography guidance alone. And one such example is as per one that you see on screen. In a pool analysis of 4 registries, you're able to clearly note that the overall degree of MACE by means of all-cause death, MI or TLR, or even cardiac death, MI or TLR, were actually significantly reduced with the utility of IVUS versus no IVUS. And more importantly, the overall rate of definite and probable thrombosis was actually reduced with the utility of IVUS versus no IVUS. This is just an example of a case from the literature. I think this is something that we all have faced before. There is oftentimes a significant degree of mismatch between what we see angiographically versus what we see after we image using intracoronary imaging. So this patient actually underwent implantation of a drug-eluting stent in the left main initially without the guidance of intravascular ultrasound or any form of intracoronary imaging. And this is the first image that you see on screen after the completion of the procedure. And 20 days later, the patient was readmitted for a non-ST elevation acute coronary syndrome. And you're able to clearly note that there was an angiographic haziness, which turned out to be a non-occlusive thrombus. And IVUS had actually revealed that the initial stent was actually underexpanded, and there was also a significant degree of malapposition amounting to the current ordeal of having a non-occlusive thrombi within the stent itself. So this is not something that is uncommonly seen with angiography-guided procedures, and I feel that moving forward for the purpose of safety and efficacy of the procedure, and this is why intravascular imaging is potentially mandatory in cases as such. We have data as well from the BCIS database that has actually very clearly demonstrated and reported that the overall degree of mortality for patients undergoing PCI for unprotected left main stenosis was actually significantly reduced when imaging was actually used. And the imaging modality that was predominantly used during this particular period was actually the IVUS, but the OCT was subsequently used in the later part of time. And the rates of OCT were also increasing towards the end of this particular study period. And data from Korea has also shown that in the performance of complex procedures, not necessarily just for left main alone, but also for bifurcation lesions, which is something that I will also be discussing today, can clearly note that the hazard ratios were very much in favor of the utility of intravascular ultrasound as opposed to just purely using the angiogram alone. And last but not least, we have data from the Rolex registry to support the utility of IVUS or OCT-guided procedures, as that has actually amounted to a much lower degree of outcomes, as you can clearly see on screen. And these are some of the other trials to support the utility of imaging versus angio-guided procedures. And I wish to also finish this particular part by stating that we all are very familiar with the outcome and results of the ACCEL trial. And I just wish to state that in this particular trial, the rate of imaging was actually very high at 77.2%. And this, I believe, had also been one of the many factors that had clearly driven the success of this particular trial. And it's interesting to note that from a survey that was actually conducted and published in 2018, in that majority of operators utilizes either IVUS or OCT, primarily for optimization of the procedural result. One would also use imaging to guide the procedural strategy. And it's very interesting to see that left main interventions as well as bifurcation interventions are actually listed as one of the factors for the utility of intracoronary imaging. However, some of the factors that are listed on screen, I believe, would actually be factors or sentiments that are actually shared by many in terms of the non-utility of either IVUS or OCT. The most common factor would actually invariably be cost. And second in line would actually be prolongation of the diagnostic procedure or the intervention itself. And third would be regulatory issues with regard to reimbursement. And last but not least would also include lack of training for the use and interpretation of these modalities. Well, personally, I do agree that there is actually a learning curve involved with regard to intracoronary imaging, irrespective of whether it's IVUS or OCT. We can actually discuss the merits between IVUS versus OCT later on, but I feel that all of these potential barriers can actually be overcome in one way or the other, and hopefully today I'm actually able to put forth my case. I wish to start by saying that I think the decision-making during PCI is very much driven by what we see after we image. And data from the Light Lab initiative is extremely promising, and I feel that everybody in the lab should actually adopt a streamlined working approach in order to increase the utility rate of imaging as a whole, may it be OCT or IVUS. So the Light Lab initiative had clearly demonstrated that the factors that are extremely important to increase the adoption of OCT would include, first, one needs to believe in the modality, one needs to adopt the utility of OCT, and following that, one needs to actually standardize the overall workflow of when you image and when you do not image. And of course, once that is sorted out, one should actually optimize the workflow and you should streamline the workflow to reduce the pre-diagnostic steps, as well as to improve the efficiency of the overall pullback. And once everybody is comfortable doing that, I think the expansion of the workflow should actually be included to increase the overall complexity of the procedures in order to get a solid workflow that encompasses every lesion subset possible. I think for a lot of us who do imaging, we feel good after we image because the information that we get is actually a lot more beneficial as opposed to just looking at 2D angiography alone. I think the more you image, the better you get. And more importantly, the more you image, the better your team gets, right? I think once there is an efficient workflow, then the overall barrier with regard to prolongation of time potentially will not exist, as everybody goes through a systematic protocol and everybody speaks the common language of getting a proper pullback, a high quality pullback that does not need to be repeated. And therefore, all of these things would actually bring about a shortening of the time with regard to the logistics surrounding the utility of imaging. And it is also important to mention that I think the overall workflow should also incorporate the utility of a systematic approach with regard to the assessment of lesions. And here you see on screen the MLD MAX protocol, which I think is an extremely important protocol to adhere to pre-procedure as well as post-procedure. One should actually assess for plaque morphology, lesion length, vessel diameter, and subsequently post-PCI, one should assess for medial dissection, stent apposition, as well as stent expansion. And interestingly, when this protocol was actually adhered to, it had actually changed decision-making in 86% of lesions, and that is actually a very high number. So some of the systematic protocols that I would show you now would actually go a long way in making sure that the procedure is actually a successful one. So in contemporary practice of PCI, it's no longer sufficient to just use imaging versus not use imaging. I think whenever imaging is used, there needs to be a standardized protocol. There needs to be a standardized workflow to improve the overall efficiency of imaging. And this particular trial, as you can see on screen, there is actually a very well-written algorithm, or rather a well set up protocol with regard to how imaging is actually done. For the ostial as well as mid-shaft lesions of the left main, one should actually ensure that all the pre-PCI factors are actually well covered, and one should also assess the post-PCI factors according to the algorithm that you actually see on screen. And this would also include IVUS optimization for distal left main lesions as well, irrespective of whether it's provisional or actually a two-stent technique that is planned upfront. Well, if a systematic IVUS protocol is actually used versus purely just angiographic guidance alone, well, then the hazard ratio to the primary endpoint is actually very much reduced as compared to just using IVUS alone without a systematic protocol. And I think this has also been shown from the data from Korea, in that if one adheres to a systematic protocol of using IVUS to pre-dilate and followed by stent sizing and post-dilation, while the overall rates of the primary outcome, which was a composite of cardiac death, target vessel MI, or target vessel revas, was actually significantly reduced. We can actually discuss the merits of OCT versus IVUS with regard to the utility of these modalities in the management of left main lesions as well as bifurcations. I think the space of left main for now would actually belong to the IVUS, but for the purpose of bifurcation PCI, I think the space then belongs to the OCT, because as you would see later on, there are a lot of other benefits that an OCT brings. For example, you would be able to guide your wire recrossing, you would be able to better identify some of the post-PCI factors. And what I've just mentioned is actually illustrated on this particular chart. As you can see, pre-PCI planning versus post-PCI planning. You have also heard from Dr. Fauzi earlier on with regard to the superiority of the OCT versus the IVUS in assessment of calcific lesions, specifically with regard to the depth. And likewise, for post-PCI assessment, the OCT use is more favorable as compared to the IVUS, in my humble opinion. We have also gotten data from the Lebanon study with regard to non-ostial left main lesions that the utility of OCT is extremely favorable if a mandatory protocol, as you see on screen, is actually adhered to. And again, I think I've mentioned over and over again about the importance of having a systematic protocol, and having this sort of an approach has actually been demonstrated to be beneficial with regard to performance of OCT for non-ostial left main lesions, in that adequate stent expansion was actually observed in 86% of the lesions. Last but not least, I wish to touch upon the fact that there is an ongoing trial specifically for the assessment of OCT in bifurcation lesions, which is the October trial. And again, the October trial would actually mandate that every lesion is assessed appropriately according to a systematic protocol. And I think that one should adhere to all of these protocols, even in their day-to-day practice, in order to conform to the highest standards of intravascular or intracoronary imaging. I think it's also important to mention that at every step, if you have a doubt about something, if there is something that is ambiguous that is going on, after every form of lesion preparation, after every form of calcium modification, irrespective of your debulking strategies, it is extremely important to then re-image and not assume that you have sufficiently prepared the vessel well prior to the implantation of a stent. Because many a times, a lot of the complications may or may not be able to be completely salvaged if the mid-run is actually not conducted. So one should actually do multiple mid-runs to even guide your wire recrossing, to assess the degree of your side branch patency, etc. And I think that would actually go a long way in ensuring that the procedure is actually a success. And the utility of imaging is also extremely important post-PCI for you to avoid accidental abluminal rewiring, which would be extremely catastrophic should the ballooning or the subsequent devices that are actually inserted through the side branch, as this may actually very well damage the main vessel stent itself. So I think it is also important that imaging would actually provide differences with regard to predictors. You've seen this slide earlier on. So all of these indices that you actually see on screen are derived from intracoronary imaging as to whether you revascularize or not. So it's actually quite impossible to decide purely based on angiography alone as to which lesions should be deferred and which lesions should undergo revascularization, or which lesions that are ambiguous should undergo physiological assessment. And this predictor that all of you are extremely familiar with regard to the prediction of angiographic in-stent risk stenosis, is in fact an imaging-derived criteria. And there are also criteria that you see on screen, or other predictors that would allow us to know whether the side branch would be compromised for the IVUS, especially if the overall MLA for the side branch, especially the circumflex ostium, is actually less than 3.7, and the plaque burden is more than 56. Well, that is actually a predictor for side branch compromise. For the OCT, one can actually use the carina tip angle as well as the branching point to carina tip length. As you see, that has been elegantly demonstrated in this particular publication. One can actually assess the tip of the carina and the length towards its branching point, which is actually the first deflection into the side branch. And do take note that the side branch angle is actually different from the carina tip angle, as you can clearly see on screen. I wish to also highlight some cases from the literature, and that both of these lesions are, or rather were, bifurcation lesions, but this lesion ended up being compromised after provisional stenting because the carina angle, or the carina tip angle, was narrow, and the branching point to the carina tip was actually relatively short as compared to the lesion that you see over here, which had a wide carina tip angle as well as a branching point to carina tip length that was substantially longer than 1.7 millimeters. OCT would actually also provide predictors in terms of the lipid arc. So this patient underwent PCI initially, but the proximal stent edge actually landed on an area with a significant degree of lipid arc, and this patient ended up having a significant in-stent risk stenosis 10 months after the stent implantation. So you can actually use all of these factors to predict when to actually use imaging, or rather where to actually place the stent appropriately. And all of these post-PCI intervention factors are all driven by targets that are actually driven by imaging. So I'll quickly move into PCI algorithms just to show you. I won't spend too much time on this, but suffice to mention that you see for the provisional strategy with regard to left main bifurcation lesions, intravascular imaging is mandatory before as well as after the procedure. For distal left main bifurcations, imaging is actually again recommended before and after the procedure. And with regard to bifurcation procedures, whether it is IVUS or the OCT, all of the treatment algorithms in contemporary PCI would actually incorporate the utility of imaging before and after the procedure. I'll now just move on to the last part of my presentation by showing you some images with regard to what we usually see on the OCT and what you see on screen with the post-PCI assessment with regard to dissection, as well as some of the assessment of the ostium of the side branch. OCT is extremely important to guide your rewiring. Sometimes you end up having a link-free carina, but sometimes the carina is not free, and you may actually want to perform kissing balloon inflation, and it's very important to know where your side branch wire is, and this can actually be achieved with the utility of OCT. An intervention with regard to risk of procedures related to complex lesion subsets, I think the patient ends up having an in-stent risk stenosis. OCT would actually be superior to IVUS for the assessment of in-stent risk stenosis. You can also use it to actually guide your wire positioning and to find out exactly why some of the devices will not go down appropriately. And last but not least, the 3D bifurcation view of the OCT is very important for you to gauge as to whether you would end up having problems like this, which is a fenestrated risk stenosis that ultimately turn out to be functionally significant. And this is actually something that you might want to address during the procedure itself, as one should actually aim to actually get a dumbbell sign after the procedure with regard to avoidance of future side branch compromise. I'll finish up by showing you two quick cases of two patients of mine with regard to left main intervention. This patient had a diffuse LAD stenosis. Left main bifurcation was clear after the procedure without any overlying struts, and this procedure was completed without any form of kissing balloon inflation. The second case involved a patient with a similar degree of stenosis, but this time around, after provisional stenting, you're able to clearly note that there were overlying struts over the circumflex of the ostium. I know that there are no systematic data to support the routine use of kissing balloon inflation, but nonetheless, I did actually perform a kissing balloon inflation to avoid instant fenestrated restenosis over the ostium of the circumflex. So in summary, ladies and gentlemen, I wish to share with you some of the statements from the EBC, in that whenever you use the IVUS to support left main intervention, the cutoff is actually 6 for Europeans, and for Asians, you have heard from prior data that it should probably be around 4.5 with regard to the MLA. And one should actually disengage the guiding catheter prior to image acquisition, and you should actually ideally image both from the LED as well as the circumflex, because of the angulation of the circumflex, the overall MLA might actually be overestimated. As you can see, the lumen here becomes oval shape and it's larger in size. So one should actually always image from both branches in order to get a more accurate reflection of what's going on. And last but not least, with regard to OCT, if you can't actually quite push it down the side branch, avoid advancing it into a jailed side branch, and one should never compromise the procedure with regard to safety. We know for a fact that aorto-ostial evaluation is now possible by means of the utility of a guide extension catheter, and the space of left main with regard to the use of OCT has clearly expanded in recent years. With that, ladies and gentlemen, I wish to thank all of you for your very kind attention, and I look forward to receiving questions. Thank you very much.
Thank you, Dr. Lee. It's very elegant lecture. So I think we all agree that when we are doing a complex case, bifurcation lesions, either in left main or non-left main, the use of
hari ini Eko dulu. Kalau mau USG-nya hari ini boleh. Mau nunggu BPJS juga nggak apa-apa. Kalau mau cepat.
I'm sorry, Dr. Babang, I think you are muted.
USG jantung.
And
tapi yang bayar dulu kalau belum ada
BPJS. I'm sorry.
So, sekitar 1,5.
I think you can help me to unmute all of the. Okay, thank you.
Okay.
We all agree that when we are doing the complex case, either left main bifurcation or non-left main bifurcation, the use of intravascular ultrasound is strongly recommended. But in fact, even in the landmark studies, landmark left main complex bifurcation studies like DK-CRAS, a definition trial, and the what you call it, master DAPT trial in Europe, the use of imaging is only 40 to 50%, right? So do you think when we cannot use because of the financial problem or something like that, what is your personal recommendation? It's better not to touch it, or we can use, let's say, stent boost to replace the coronary imaging. What is your perspective? Thank you.
So I think contemporary trials are different with regard to, first and foremost, the utility of devices. I think naturally newer generation stents have much better safety data with regard to first generation stents, for example, and that clearly has also contributed to the success of some of the contemporary trials. Most definitely, I think in terms of the utility of fluoroscopy, guided approach by means of stent boosts, etc., that is also going to be extremely helpful. And that is also a part of the advancement of technology as to how we can further optimize the PCI procedure. Personally, I feel that the issue of cost is something that is rather tricky, because if a patient were to end up having a target vessel failure, for example, and he or she requires another revascularization later on in their lives, I think all of these readmissions and rehospitalizations would invariably increase the cumulative cost per lifetime for a patient. And this is also going to be significantly impacting on the overall healthcare system as well. So many a times, I think with a slight increment with regard to short-term cost, this is going to go a long way in reducing the overall long-term cost of the procedure, as over time, we have clearly seen supporting data from a large population of patients that both intracoronary imaging as well as physiology have definitively been shown to improve outcomes. So that is my personal take on things.
Thank you, Dr. Lee. I think we should proceed to the other speakers, and Dr. Lee will take over for the rest 3+ speakers. Thank you.
Okay, well, thank you very much. So we are into our 4th talk now, and it gives me a great pleasure to introduce the next speaker, which would be Dr. Wonpak Monkau from Thailand. He's actually the director of the Cardiac Catheterization Laboratory at Thammasat University Hospital, and he will deliver his lecture that is titled Intravascular Imaging Guidance in PCI Management of Chronic Total Occlusions, CAD, as to whether a CCTA roadmap is still needed. Dr. Moonpak, time is yours.
Thank you very much for your kind introduction, and thank you APSC for inviting me to talk in this session. So my topic is the intravascular imaging guidance in the PCI management of CTO, and is coronary CTA roadmap still needed? So I will divide my talk into 2 parts. The role of intravascular imaging in CTO intervention and the role of coronary CTA. So first part is intravascular imaging guidance. So as you know that in CTO lesion, IVUS play a more important role than the OCT. So for the IVUS application, we can use the IVUS both antegrade and retrograde approach. And for antegrade approach, we can use the IVUS to identify the proximal cap and to guide the penetration of the antegrade wire into the cap to confirm that the wire is in the plaque or is in the subintimal at the entry. And we can use IVUS for the re-entry technique. For the retrograde approach, we can use the IVUS to identify the guide wire position and to facilitate the reverse cut by identifying the location of the retrograde and the antegrade guide wire to each other, and to select the proper size of the balloon to do reverse cut, and to monitor the retrograde guide wire after crossing into the proximal true lumen before entering the guiding catheter. So I will show you the case that I use the IVUS for this purpose. So this is a case of mid-LAD CTO, which mainly receive the collateral by the ipsilateral septal channel. Okay. And in this particular case, the proximal cap is ambiguous, and we cannot be sure that the proximal cap is here or is here. So in general, we should use the IVUS to make the to make sure that where is the site of the proximal cap before we do the antegrade puncture. So in general, we can put the IVUS into the side branch adjacent to the CTO lesion and pull back the IVUS, and we can identify the proximal cap location. So in this case, I put the IVUS into the septal branch and pull back, and you can see that from 7 o'clock, this is the proximal stump of the CTO coming. So I do the IVUS marking by leaving the marker of the IVUS catheter there and do the angiogram to mark that this is the location of the proximal stump. So it should be here, the proximal stump, not here. So after that, I can do the antegrade puncture with the guide wire at this point, and I check again the location of the guide wire. So you can see that so the antegrade guide wire is in the center of the plaque. So this should be intra-plaque wiring, not the subintimal wiring. So if you see the guide wire periphery, this is the high risk for subintimal tracking. But if your guide wire is in the center of the plaque, it's likely to be the intimal plaque tracking. So this is how we can use the IVUS to identify the proximal cap and to guide the penetration of the cap by confirming the intimal plaque position of the antegrade guide wire. So in the same case, after I advance the guide wire down, the guide wire went subintimally. So I switched my approach to the retrograde, and I use the ipsilateral septal channel to put the retrograde wire up here into the mid part of the LAD. But the retrograde crossing is not successful by the direct crossing and the reverse card technique. So I decide to do the IVUS from the antegrade wire to understand the position of the antegrade guide wire and the retrograde guide wire. I want to know the relationship of both wires. So you can see from this IVUS study that the antegrade wire is in the subintima and the retrograde wire here is in the plaque. But at this point, the retrograde guide wire went into the subintima. So to be summarized like this, so at this point, the retrograde guide wire is in the plaque, antegrade is in the subintima. At this point, retrograde intraplaque, antegrade subintima. And at this point, both guide wires are in the subintimal space. And here, only antegrade guide wire in the plaque. And here, at the point of the bifurcation between LAD and septal branch, the antegrade guide wire is in the proximal true lumen. So, which is the best position to make the connection between the two wires should be here, because both guide wires are in the same space. So if both guide wires are in the same space, it's easy to make the connection. And but if the antegrade guide wire is in the subintima and the retrograde guide wire is in the plaque, this is the most difficult pattern to make the connection between the two guide wires. So you should find where the guide wires are in the same space, like this or like this, and this is okay, but this is difficult. So in this case, this point is the base to make the connection. So I use the bigger balloon here, and I do the reverse card here by puncture with the guide second into the space created by the balloon. And this is how we can use the IVUS to identify the guide wire position and to facilitate the reverse card by identifying the location of retrograde and antegrade guide wire to each other, and to select the proper balloon size for reverse card. And after retrograde wire crossing, you can use the IVUS to monitor the retrograde wire position that it went into the true lumen, not into the subintima. So in this case, after retrograde wire crossing, I have to advance the retrograde wire through the left main into the guiding catheter. I can put the IVUS here in the left main to make sure that the guide wire went into the proximal true lumen into the left main, not into the subintima, before entering the guiding catheter. And after that, the revascularization was successful. And another case is the CTO of the left circumferential artery. And in this case, the operator advanced the anti-gate guide wire, but it went into the subintimal space. But he didn't know that, and he dilated, and he checked the IVUS. But from the IVUS finding, the wire was in the subintimal space. So we can use, in this situation, we can use the IVUS to guide the rewiring into the distal to lumen. So we can put the IVUS into the subintimal space like this. Here you see that the IVUS is in the subintimal space. Here is the distal to lumen, and this is the pericardium. So from the anatomical viewpoint, this is this is the pericardium. So pericardial side is here. So pericardial side is here, and the distal to lumen is here. So distal to lumen is this side, the LV side. Let's say it's the same direction as the OM branch and the same direction as the LV side. So I know that in this case, to reach the distal to lumen, the second wire must be advanced more on the ventricular side. So I suggest the operator to advance the second guide wire more into this side, the ventricular side. So from knowing the information from the IVUS, we can successfully re-enter the distal to lumen only in one attempt. So check IVUS again, and now the wire was in the distal to lumen. So this is how we can do the re-entry by the IVUS guidance. So my next talk is about the need for the CORI CTA. So talking about the pre-procedural planning for the CTO, I think the CORI CT angiography play the most important role, and the CT can tell us about the presence and the location and the degree of the calcification, and we can know the vessel size and the vessel root, about the tortuosity of the vessel from the CT. We can assess the stump morphology and the presence of the multiple occlusion and lesion length from the CT information. Moreover, we can use the CT to assess the myocardial mass at risk, which we can calculate from the length of the branch that we are going to do the revascularization to predict the benefit of the revascularization to that artery. And this information is significantly related to the actual myocardial mass at risk from the pathology. So we can know the benefit of revascularization from that lesion. And the CT can assess the calcium. So in case of the calcium with the large mass or the full moon appearance or the complex distribution intraplaque, this can prevent the guide wire. This can prevent the advancement of the guide wire. But if the calcium is like a circumferential, but is peripheral, it can be like a guardrail to prevent the guide wire from going outside the vessel. But in this type of calcium, the guide wire is easily to go subintimally. And about the CTO route, the CT can give us very useful information. So you can see that from this case, actually the vessel route is very tortuous, like this. And if we know this information from the CT, we can advance the anti-gate guide wire safely if we know the real vessel cost like this. And this is how we use the CTO to assess the CTO entry. This is the CTO of the ostial LAD. And you can see that in this case, I use the IVUS to check the proximal stump. But you can see that even we can see the proximal stump coming here from 1 o'clock, we cannot see it clearly because of the calcium. So the calcium make us obstruct the IVUS, the ultrasound, so we cannot see clearly here. So this is the limitation of the IVUS. But from the CT information, we can see that the CTO of the LAD is close to the small side branch here, and there is a lot of calcium here. And this is the root of the vessel. So we know the root of the vessel here, and we know the position of the proximal entry to be here, close to this branch. So to puncture here is not correct. So we should puncture close to the branch and in this direction. So this is correct. So according to the CT information, we can be sure about the root of the vessel. So you can see that even after the anti-gate puncture, I check the IVUS again, but cannot easily see beyond this calcium. So this is the limitation of the IVUS guided puncture, the calcium at the proximal cap. And if there is no side branch near the proximal cap, or the side branch is too small, or extremely angulated, or there is an osteostenosis of the side branch, we cannot deliver the IVUS into the side branch. But CT can help us. So in this case, I advance the guide wire, and we can get success. And about the CTO exit, I will show you this case. So this is the CTO of the proximal LAD. And you can see that there is no clear collateral vessel to the distal part of the LAD from the left choric system and the right choric system. You cannot see the distal LAD clearly. And so this procedure was done, and the previous operator failed to revascularization the vessel because he had no idea about the distal to lumen and the cost of the vessel. So after he advanced the guide wire, it went into somewhere, not into the distal to lumen. So before we try, we check the IVUS, and this is the SLAP MIP reconstruction of the CT. So you can see that in this particular case, there is a separate conus branch from the aorta here. And this conus branch supply the collateral to the distal to the CTO lesion. So conus branch here and connect to the mid part of the LAD. And you can see that in the previous angiogram, the catheter was too deep, so we cannot see the conus branch. So after we know this information from the CT, we bring back the patient again, and this time I did the tip injection into the side branch, and you can see that from tip injection in the side branch, you can see clearly the distal through lumen, and you can see that actually the CTO length is not very long, and vessel cost is like this. So with this information, I successfully revascularize this vessel. So in conclusion, I think the usefulness of IVUS in CTO PCI is very apparent. And the Cori CTA provides more detailed assessment and optimize the procedural plan for CTO operator. And what I want to emphasize is to review the CT by yourself, because one image has two different interpretations depending on the specialist that read it. For example, this image, the radiologist should interpret it as the CTO is 100% luminous stenosis, and the calcium is a blooming artifact. Is a blooming artifact, but for the interventional cardiologist, the CTO, we should assess the proximal cap, the length, the cost, and the plaque composition, and the distal vessel and the associated side branch, and the calcium we can use as the landmark. And for the imaging guidance of CTO intervention, I think Cori CTA and intravascular imaging are complementary to each other. Thank you very much for your attention.
Well, thank you very much, Dr. Muntak, for an excellent lecture. I'm sure all of us have been extremely intrigued with all that you have presented with regard to CTO PCI, both with the utility of CCTA to actually complement the use of intracoronary imaging as well. So perhaps I would start off by asking you, Dr. Muntak, what sort of lesions, or rather, are there any predictors that you would actually use after the diagnostic angiogram itself to say that you would actually take the patient off the table, do a CT, and then come back and reattempt the procedure? Would you have any advice for that sort of situation?
Yes, I think, thank you for your question. I think
Dr. Muntak, you're actually muted.
I'm sorry. So thank you very much for your question. And I think the mainly reason to stop the procedure and send the patient to the CT is the unknown vessel cause. So especially in the long CTO lesion, and we are not sure about the vessel cause and the vessel size, and I think we should it's better to stop and then send the patient to the CT, and as well as if you try the anti-platelet approach and you fail, and there is a lot of calcium, so we maybe sometimes I stop and I send the patient for the CT and to check the relationship of the calcium and the lumen, and you can know that which direction is better to advance the guide wire to less calcium side. I think the main reason is the vessel cause. Yes.
Well, that's great. Thank you very much. Dr. Bambang, you have a question for Dr. Muntak?
Yes, please. Thank you. So, okay, again, actually, I have asked Dr. Fauzi, but remain unanswered. So let's say you have patients with CKD and estimated GFR is less than 50. Then, do you think using the CT calcium score, we still can use as a roadmap? Because sometimes, diffusely calcium, we can see even without contrast. What do you think? Thank you.
Yes. I actually I totally agree with you. So if we can use the CT, sometimes when we bring the patient to do the PCI, we can use less contrast in the procedure. So we use the contrast for the CT, but we get a lot of information. So in the procedure, we use less contrast and we use a less time for the procedure. So I think maybe that is the important point. And if we have the software to use the CT roadmap, and when we change our angiographic view, the CT reconstruction changed to the same view, and this helps very much. Yes, I highly agree.
Thank you, Dr. Montek.
Okay, that's great. So I think in the interest of time, we would need to move on to the next speaker. Once again, thank you very much, Dr. Montek. So the next speaker is Dr. Do-Yoon Kang from Asan Medical Center, Korea. Dr. Do-Yoon Kang. I see Dr.
Yeah.
Hello, Dr.
Yes.
Do-Yoon Kang.
Okay,
so
I
Dr.
wanna,
Do-Yoon Kang.
yeah,
Sorry?
I wanna share my screen, but I cannot because
Okay.
yeah.
So
Okay.
maybe the technical support can help.
Okay, now I
Dr.
can.
Kang.
Yeah.
Okay, great. Okay, great. So Dr. Do-Yoon Kang would speak to us about intravascular imaging guidance in multivessel PCI, management of chronic coronary syndrome in comparison with multivessel CABG. Dr. Do-Yoon Kang, the time is yours.
Yeah, thank you. I'm Dr. Kang from Asan Medical Center in Seoul, Korea. Today I will talk about intravascular imaging guidance in multivessel PCI of chronic coronary syndrome, and especially for the comparison with the CABG, because we recently have published the paper about this topic. Maybe the APSC committee would invite us. Now the ESC guideline 2018, the recommended elective PCI for triple vessel disease with the low syntax score as 1A for CABG and both PCI, and high syntax score, the recommended CABG. But in recent US guideline with the findings of the ischemia trial and many more recent trial results, totally different recommendation. The multivessel CAD with anatomy suitable for PCI or CABG, if it is not, just recommend guideline-directed medical therapy. If it is suitable for PCI or CABG, and if the patient has ischemic cardiomyopathy and suitable for CABG, and recommend CABG for recommendation grade 1 or 2A. And if the patient is not suitable candidate for CABG by anatomy or the clinical characteristics, and after heart discussion, GDMT with or without PCI is recommended. Then what would be the stability for PCI? Or ischemic lesions, then the diameter stenosis more than 80% and the large or not very small vessel disease, and FFR and IVUS for multivessel disease strongly recommended. And how about the CABG? Anatomically, all coronary arteries with more than 70% stenosis and 1.5 millimeter diameter should be revascularized. It was from the syntax trial, the inclusion criteria. But functionally, all ischemic myocardial areas should be grafted. It would be the anatomic suitability for PCI and CABG in guideline. Then how about the ischemic cardiomyopathy with the ejection fraction equal or less than 50%, and low ejection fraction is the only important intact to do CABG. All patients with a low ejection fraction, CABG is recommended as a first line. And the guideline, now in US guideline, do not mention about the syntax score. Then because this is the mention in the guideline, the usefulness of the syntax score calculation in treatment decision is less clear because of the inter-observer variability in each calculation and its absence of clinical variables. That's why the syntax score is now deleted in US guideline. And let's review the data. Low ejection fraction. Is it the only important index to do CABG? Is it real? Is it right? For multivessel disease, there are two trials in CABG versus medical treatment for multivessel disease. One is CAST trial, second is STITCH trial. Only two trials, very limited data. The CAST trial is the first randomized trial that randomized patient by the CABG versus medical therapy in stable coronary disease. It was published in 1983. As you can see, it's 40 years ago. It included 780 patients by the surgery versus medical therapy, and 70% was one or two vessel disease. And it's because it's 40 years ago, nitrate and beta blocker available in less than 50%. So the symptom control by the medication was not appropriate. And the all-cause mortality was similar between surgery and medication, and it has a similar trend in 1 or 2 or 3 vessel disease. But in patients with a low ejection fraction, the surgery looks a little bit better trend of the mortality, and in triple vessel disease, a trend of a little bit better in surgery patient. And the conclusion of the CAST trial was that CABG would be better over medication in patients with a stable angina and average ejection fraction less than 50%, the others concluded. And the next trial, the only good and big trial about the CABG versus medical therapy with the multivessel disease and ischemic heart failure is STITCH trial. It was first published 10 years ago, and the 10-year result was published in 2016. It included 1,212 patients with a stable angina with a low ejection fraction less than 35%. And the patients was randomized to surgery and versus medical therapy. And the triple vessel disease was 60%, and two vessel disease was 30%. So we can say that it is the trial for multivessel disease. And all-cause mortality at 10 years was better in CABG group with a hazard ratio 0.84, and cardiovascular death was also better in CABG patient with a hazard ratio 0.79. So we can say that CABG would be better over medication in patients with a stable angina less than the ejection fraction less than 35%. That's why the guideline recommend the triple vessel disease or multivessel disease with a ejection fraction less than 50% as the recommended with a CABG. One for recommendation grade 1 with a STITCH result with a ejection fraction less than 35%, and 35 to 50% by the CAST trial result. Then in this kind of result, patient, the CABG would be better. Then how about the normal ejection fraction with the triple vessel disease? The US guideline recommend CABG versus PCI as the 2B recommendation, both. Any revascularization by 2B. 2B has a weak recommendation that benefit outweigh the risk a little bit, and it might be reasonable, it might be considered because usefulness is unknown, or not well established. Why 2B? We think that the triple vessel disease and then the PCI or CABG would be needed. However, the guideline is very weak because of the trial result of the ischemia study. It included the stable coronary artery disease with a moderate or severe ischemia patient in more than 5,000 patients. And the patient was randomized into initially invasive strategy by the CAG and subsequent PCI or CABG versus initially conservative strategy with only medical treatment. And the primary outcome of the composite of death from CV cause and myocardial infarction or hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest was the primary endpoint. And coronary anatomy by the CT shows that the multivessel disease patient was more than 75%. In those patient group, primary outcome at 3.2 years was similar, not different between conservative and invasive strategy. All deaths was same in both groups, and myocardial infarction, the invasive strategy shows a little bit lower in long term, but the peripheral myocardial infarction was higher. And in extended 7-year follow-up of the ischemia trial also shows the same death rate in both groups. Cardiovascular death was a little bit lower in invasive strategy. However, the non-cardiovascular death was a little bit higher in invasive strategy. So all deaths was not different between two groups. By this data that no survival and ischemic event benefit of invasive strategy was shown. So the patient, even with the multivessel disease and moderate or severe ischemia, initial invasive strategy with the asymptomatic patient is not recommended. So optimal medical therapy is good enough for majority patient with stable coronary disease with tolerable symptoms. Therefore, the guideline recommends any revascularization as 2B weak recommendation. Then how about the PCI versus CABG for multivessel disease? There are 5 trials, BAR2D, Freedom, Syntax, Best, Fame, but still limited data. Bari-2D with a diabetic patient, 2009 showed that PCI had no benefit over medical therapy in low-risk patient. It randomized the patient into medical the revascularization versus medical therapy. And the revascularization was done by PCI or CABG. The PCI group did not show benefit, but CABG group showed the benefit in the freedom from MACE, death, MI, or stroke. So the CABG was better than medical therapy. In freedom trial with a diabetes and multivessel CAD, 5-year follow-up, the CABG showed better primary composite of death, MI, stroke compared to PCI, but and also for the death from any cause in very long-term follow-up. The freedom follow-on study of the 7.5 years also showed that all-cause mortality was better in CABG group than 24 versus 18%. The Syntax study, it has the left main and triple vessel disease subset. In triple vessel disease subset, all deaths was the lower in the CABG group by 28 versus 21 with the statistical significance. The CABG was better. And also in FAME trial, FAME3 trial, they enrolled 1,500 patients with a triple vessel disease, and half was done by FFR guided PCI, and half underwent CABG. The MACE rate, death, MI, stroke, or repeat revascularization at 1 year was not non-inferior in PCI. The PCI failed to show the non-inferiority over the CABG group. But the FAME3 trial has the weak point that one is that the many patients, only 20% patient underwent FFR, had the negative FFR. That made FFR did not affect the clinical decision making in not so many patients. Another thing is that intravascular imaging, even in triple vessel disease, was used only in 11.7% of the patient. And we now published the best trial from Asa Medical Center last year with a 10-year follow-up result. It showed that the death rate between PCI versus CABG was similar, not different, even in 10-year follow-up. Let me show you the detail. The best trial was initially published in 2015 in NEJM about the multivessel disease that compared overall illuminate the giant stent PCI versus CABG in multivessel coronary artery disease. The hypothesis was the PCI would be non-inferior to CABG with respect to 2-year MACE. And it was initially designed to random the 1,700 patients. However, it was prematurely stopped with the 880 patients because of the slow enrollment. And the primary endpoint was better in CABG group by the death, MI, or TVR. We extended the trial with a 10-year, and the inclusion was same with the original trial with the diabetes stenosis 70% more or more multivessel disease. And we randomized 808. Is it okay? Okay, 808 patient, and it's follow 10 years. And the PCI was CABG, mean age was 64, and the diabetes was in the 40% of the patient. And about 7% of the patient underwent PCI previously, and the patient or the 3% of the patient had a heart failure history. And the Syntax score was about 24. The characteristic, the very important point of our trial day is that in PCI group, more than 70% of the patient underwent IVUS guidance, and complete revascularization was done in 50%. And CABG group, number of grafted vessel was 3.1, and arterial graft was 2.1. The medication, because it's a very recent trial, many patients they took the depth after discharge, and about more than 90%, even in 10 years, the prescribed statin, and more than half patient prescribed beta blocker or ACE inhibitor or ARB. The primary endpoint, STEMI and TVR, was not different between groups. The KBG shows a trend of a little bit lower in nominal, but it was not significantly, not statistically different, even in the less than 5 year and after the 5 year. And SMI or stroke, the hard endpoint, was also not different between PCI and KBG in 10 years. That's from any cause, no absolute difference. And any repeat revascularization, the KBG was better compared to PCI. The KBG is better in decreasing repeat revascularization, but not different in hard endpoint like death, stroke, or myocardial infarction. Long-term outcomes, the spontaneous MI showed a little bit better, a little bit higher trend in the PCI group, but mainly was the non-target vessel-related myocardial infarction it was. And the any revascularization was higher in PCI group, and also non-target lesion revascularization was higher in PCI group. That means that in PCI group, treated vessels shows the similar outcome versus CABG, but non-treated, non-PCI treated vessels develops and progress and make the clinical outcome in long term. In subgroup analysis, only diabetes has some interaction. The important thing, the very interesting is that this figure, the PCI without IVUS, the blue line, has the worst clinical outcome. However, the patient underwent PCI with IVUS, the red line shows similar clinical outcome with the CABG. Even in hard endpoint and or death, the patient with the PCI with the IVUS shows not different outcome with the CABG. This is a primary endpoint, and that's from any cause. You can see that the patient without IVUS shows the higher the clinical event rate. However, the patient with underwent PCI with the IVUS shows similar clinical outcome, even with CABG in multivessel disease. So this is the now guideline. Then this is a summary of the guideline. The CABG and PCI for patients with the multivessel disease may be considered. The patient with the diabetes who have triple vessel disease should undergo CABG in guideline. If they are poor candidate for CABG, PCI may be considered as a 2A. However, we have still limited data interpretation about that all studies use the first generation DES, except for the best trial that used Giants, and lack of concept of physiology and imaging of PCI in the body to this freedom or syntax. And also there are some limited issue of complete revascularization. So we have to consider physiology and image support some of the contemporary PCI. It would be totally different world, because in the contemporary PCI, we select the region with the physiology and optimize PCI with the intravascular imaging. The clinical outcome would be much better than before. The impact of physiology and imaging is well shown in Syntax 2 trial that measured IFR and FFR in measured lesion, and 84% of the IVUS used, and the MACE was totally different. In Syntax 1, the number of treated lesion was 4, but Syntax 2, number of treated lesion was 2.6. And triple vessel disease was less than half. And also, in Syntax 2 trial PCI, the blue line is similar with the Syntax 1 CABG. That means that with the intravascular imaging and physiology guided contemporary PCI can make good clinical outcome compared to the CABG. The message from the Syntax 2 means that the contemporary PCI can be totally different strategy and has totally different clinical outcome compared to conventional angio-guided PCI. And as I showed you in best trial result, the PCI with intravascular imaging in our center, in our the clinical trial, best trial with the second generation DES and contemporary medication, the IVUS guided patient showed similar clinical outcome even with the CABG. Even with the recent clinical trial from Korea, Renovate complex PCI trial that enrolled complex PCI randomized 2:1 by imaging-guided strategy and angio-guided strategy. It included CTO bifurcation and also multivessel disease, and showed significant clinical benefit of the target vessel failure in imaging-guided PCI. So in complex PCI, the imaging guidance can help to improve the clinical outcome. Why? We published the data from the IRIS-DS registry, the patient with the complex coronary artery disease, and the patient underwent imaging-guided pre-dilation, stent sizing, post-dilation that showed stent number was lower, stent number was higher, stent length was longer, stent diameter was bigger, final balloon size was bigger, and the clinical outcome was better when we used the imaging, intravascular imaging, and imaging-guided post-dilation, pre-dilation, and stent sizing. And the most important part was the post-dilation imaging-guided PCI, and because it made the post-dilation bigger, one step size, 0.3 size was bigger in patient with the intravascular imaging compared to the angiographic guided PCI. So many trials shows that if we do the intravascular imaging and make optimal stent expansion, then clinical outcome would be better. So in the intravascular imaging, I can implant bigger stent with a higher pressure post-dilation safely, and those kind of small details can make a big difference. So let me conclude my talk, my approach for multivessel disease. So revascularization plus medical therapy. And the treatment should be individualized according to the different CAD severity, ischemic severity, and stability for PCI or CABG, LV dysfunction. And the ischemia trial also shows that all-cause mortality is higher in patient with the triple vessel disease or two vessel disease with the proximal LAD. The mortality is related to the total atherosclerotic burden. So high-risk patient with the triple vessel disease or two vessel disease with the proximal LAD, revascularization. Intermediate or low-risk patient, medical therapy. And how about the revascularization? For ischemic lesion, favorable anatomy for PCI, and complete ischemic revascularization with the DES and intravascular imaging guidance. And unfavorable anatomy for PCI and also possible major vessel PCI with the optimal medical therapy, or poor anatomy or low ejection fraction, I will consider CABG first. Still, we do not have the data about the contemporary PCI versus CABG in ischemic cardiomyopathy, and the Stitch 3C trial is ongoing. We'll compare two strategies. And contemporary PCI versus CABG with diabetes, and we need more data. So in our center, we are now beginning the trial, the defined DM. In DM, multivessel disease with the imaging and physiology guided state-of-art PCI versus standard CABG. We will compare to 1,200 patients in those groups. Thank you for your attention.
Well, thank you very much, Dr. Kang. That was an excellent summary of PCI versus CABG data. I particularly like the fact that from the best study, we saw that IVUS guided PCI was equivalent to CABG, and this is very much in line with all that we've been discussing so far. I think I would just like to ask you one question. We know that physiology guidance in the space of multivessel disease, primarily for the purpose of PCI, is very clear from all the data that we have. But what are your thoughts about pre-CABG planning with the utility of physiology? Because as we know, the target vessels might be a little bit different as to what the surgeons would actually revascularize versus ourselves as interventional cardiologists. So what are your thoughts about physiology guidance with regard to pre-CABG planning?
That's very excellent question, and we have a lot of things to discuss about that. But actually, there is no robust data yet about that, no data yet. But actually, we are in our center, we also recommend the FFR guided revascularization in many patients, with even for the CABG. And because the many vessels with the intermediate disease, and surgeons do not do not know which vessel is significant. And 50% or 70%, as you see, the 50, 70 node is very visual. It's not accurate. Even everyone says the different numbers. So FFR can guide those patients with a significant the ischemia producing lesions in CABG. But some surgeons says, and also that the role of CABG is to prevent future MI with adding the flow, the distal to the lesion. So even with the FFR negative lesion, the grafting can be the protective. So we do not know about which would be true. So in FFR guided CABG, we can select the only lesions, the only vessels that is significant, so we can save time and save energy and save a vein, and also we can save that. And also, in opposite part, someone says that the grafting the whole vessel would be more protective for long-term clinical outcome. So we are collecting the data, and sometimes we can show you.
Well, that's great. Thank you very much. Maybe we just have one question from Dr. Bambam before we move on to the next speaker. Dr. Bambam.
Thank you, Dr. Lee. I think I agree that physiology studies should be a part of diagnostic procedure, no matter what the option, PCR or CABG. That's I think that's a very good point. And secondly, I think comparing PCI and CABG by using composite endpoints is really unfair. Why? Because CABG actually may anticipate the disease progression because they put the graph in distal segment of the artery, and stent just spot treatment, meaning that cannot protect for the disease progression. So I think the most important hard endpoint should be that target vascular revascularization is not the point, because we can do it. Just use the drug-coated balloon if there is any IVUS. Thank you.
I totally agree with your opinion. Totally, 100%. Yeah, this is the most important. And TVR, I asked the many patient or our fellow that one CABG and and the one PCI, how many PCI will be equal to one CABG? Someone says 3, or someone says 5, but it would not be equal.
Thank you.
Okay, thank you very much, Dr. Kang, for your time. We now move on to our final speaker for today, which would be Dr. Satoshi Mogi from Hamamatsu University School of Medicine in Japan. So Dr. Satoshi will speak to us about intravascular imaging guidance in percutaneous transcatheter intervention of peripheral arterial disease. So we are moving on to a different space now. And in this particular topic, whether CT angiography roadmap is still needed. Dr. Satoshi, the time is yours.
Thank you, Chairman. Okay, I will share my slides. Okay, thank you, Chairman. I'm Satoshi Mogi from Japan. This is my honor to be presenter at this great web meeting. My topic is a CT roadmap for peripheral interventions. As you know, computed tomography angiography, CTA, has multiple advantages compared with other vascular imaging modalities for the evaluation of the lower extremity vasculature. We can get various information from CTA, lesion length, minimum lesion area, reference diameter, and plaque character. Especially calcified plaque location is very important, especially iliac interventions. We can recognize the distribution of calcified plaque with 3D CT workstation before procedure. This is a representative case. Vessel lumen completely obstructed by calcification with no residual flow or thrombus. Pre-procedure region information may change the practice. We can adjust the image, axial image, or coronary image, or sagittal image. So Therefore, guidelines strongly recommend CT for symptomatic peripheral artery disease patients before revascularization. This is ESG guidelines, and same as SVS guidelines, and also APSC guideline has the same things. Today, my topic is CT angio roadmap. As you do daily practice, roadmap technique is established tool for peripheral intervention. This is a very old paper which indicates the efficacy of DSA roadmap for neck interventions. It was published 40 years ago, very old. To make DSA roadmap, first we do angiogram by data subtraction, and then technician make a roadmap. Then we can recognize a target like this. However, there is a problem of the DSA roadmap. If we move the table, roadmap will disappear. Now, it is possible to fuse previously acquired CT image with real-time fluoroscopy. Furthermore, the fusion is maintained even if the table is moved or the angle is changed. This is some representative case. I'd like to show you some cases using a 3D CT angio roadmap. This patient has a significant stenosis at right external iliac artery. Control angiogram showed ulceration at the stenosis site. So we fused pre-procedural CT data with fluoroscopy like this. The wiring was successful with attention to ulcer by CT image. After pre-dilatation, we deployed 8 mm self-expandable stent via radial artery. Now we can see stent position clearly with the CT roadmap. This is a final angiogram. Vessel is well dilated. Next case is a left SFA case. Patient has significant stenosis at proximal SFA and mid distal SFA occlusion. As you see this volume rendering CT, left SFA originates from high position. Such a case, to avoid SFA or DFA puncture, we often use contralateral approach. However, in this case, we choose ipsilateral approach due to iliac angle. It is bending and the concern of wire manipulations. To avoid SFA puncture, we use CTA roadmap like this. We could puncture just above the SFA ostium and achieve revascularization with drug-eluting stent for proximal SFA and drug-coated balloon for distal SFA. Next case is a left SFA CTO case. As you see by angiogram, CTO length is relatively long and there is not so significant calcification at the SFA. So it is difficult to recognize CTO vessel course by fluoroscopy. So we did a CT roadmap. After CT roadmap, we can easily choose SFA. We can recognize the wire position, and of course, we can easily manipulate the wire position, this CT angiogram guidance. Then we can achieve CTO penetration. Next case is a long right SFA pop CTO case due to femoral popliteal bypass failure. Patient has a history of aortofemoral bypass and femoral popliteal bypass. Femoral popliteal bypass was occluded. And this angiogram showed the very long CTO. Proximal SFA was occluded, and also distal to popliteal artery was occluded. And unfortunately, this patient has impaired linear function. So we did non-contrast CT for pre-procedural assessment. Iliac artery and SFA have large diameters and are easy to trace. So reconstruction is possible without using a contrast agent. After tracing vessel with each slice of non-contrast CT, we can reconstruct 3D image like this. After CT and roadmap, we can recognize SFA ostium. In this case, unfortunately, we need a retrograde approach. SFA vessel course can clearly indicate with this CT roadmap. It helps retrograde wiring. Finally, we got beautiful one straight line. I showed some cases which CTA roadmap is useful and helpful. By the way, is CTA roadmap more effective than conventional method? From Japan, small observational study was published. Patients were divided to two groups. One is treated by CTA roadmap, and another is a conventional method. The number of patients is not so big. The outcome is wiring time. The patient characteristics were not different between two groups, CTA roadmap group and the conventional group. And the mean CTO length is 10 centimeter. This table is the main result. Wiring time and the number is significantly smaller in 3D CTA roadmap group. Also conclude EV endovascular treatment with CT roadmap for iliac CTO provides a high procedural success rate and low complication rate with fewer guide wires and shorter wiring time to pass through the CTOs. Of course, CTA roadmap has some limitations. If the position of the leg at the time of CT and endovascular treatment are different, the fused blood vessel course may be different from the actual one. This technology is dependent on your machine. You need contemporary machines. Present video are obtained by Torinius. Torinius is a product of Shimazu, Japanese company. It provides good peripheral images. It's called moving DSA. As you see, very nice photo we can get just after the finish the chasing and injecting. We can get this great photo within few seconds. Ladies and gentlemen, this is my conclusions. CT angiography roadmap still needed? My answer is yes. Pre-procedural CT is useful for peripheral intervention and helpful. CT mapping is helpful for operators. Thank you for your attention.
Well, thank you very much for the wonderful presentation, Dr. Satoshi. I thoroughly enjoyed. This is a different space compared to all that we've been discussing today, which would actually involve the peripheral space as opposed to the coronaries. I think it is important to also mention that the machine is needed, as not every cath lab is actually able to provide this sort of an advanced assessment with regard to CT and geography real time. With regard to that, I think a lot of other setups would actually still undergo the conventional CT at radiology, I mean, and not real time. And how relevant is this still in your practice, and how much, I know you have got the access to the CT angiogram itself, but what do you think is the role of the conventional CT angiography that is done at radiology in a non-real-time setting with regard to your assessment of peripheral arterial diseases?
Thank you for good questions. And for interventional cardiologists, sometimes we need severe atherosclerosis conditions. Patient have three vessel coronary disease. Also, patient have iliac stenosis or occlusion. Such a time, we have to approach a iliac artery or common femoral artery to make an access site for support device for PCI or CABG. So we need the skill of iliac intervention. In such a case, CT information is very useful for and the safety. I think calcification is a very risk for peripheral intervention. So conventional CT, not so fusion image, tell us a lot of information. So I think conventional CT is also important for peripheral intervention. Thank you.
Well, thank you very much. Perhaps a question from Dr. Bambam?
No, thank you. I don't do peripheral intervention.
Okay, okay. Any questions from the rest of my esteemed colleagues that I still see online? Dr. Fauzi, Dr. Kang, Dr. Muntak.
There is a question in the chat.
Okay.
Yeah. What is the role of, sorry again, intravascular ultrasound in peripheral intervention? I think the question.
Yep.
Okay. Yeah.
Thank you for your good questions. And from Japanese data, conventional angioplasty for below the knee is for the clinical limb ischemia for critical CRI patient. However, if we use the IVUS, with fluoroscopy, we can consider that vessel may 2.0 or 2.5. Actually, IVUS tell the true diameter, and maybe below the knee artery is more than 3 or 4. So if we can use IVUS for BK intervention, it will make good dilatation of BK arteries. Thank you.
Okay, thank you very much. So I think if there are no further questions, every good thing must come to an end. It is time for me to call this session to a close. I trust that all of you that have joined us today have found this session extremely educational and enriching at the same time. I think we have covered the full spectrum of the utility of imaging, may it be intravascular imaging or the role of CT, etc., to guide our procedural planning for a wide subset of lesions, from the coronary to the peripheral space as well. I wish to especially thank Professor Junie Lin, who is the Program Director of the APAC Cloud Forum in Cardiovascular Disease webinar. Thank you very much, Professor Lin, for the inclusion of all of us today. We thoroughly enjoyed ourselves. I wish to also thank my co-chair, Dr. Bambam Budiono, for the wonderful co-chairing session. And of course, I would also like to thank my esteemed colleagues. Thank you very much for your contribution. Dr. Eric Sison, Dr. Fauzi Yaya, Dr. Muntak Mankau, Dr. Duyun Kang, as well as Dr. Satoshi Mogi. And of course, last but not least, I wish to also thank all the participants today for spending your time with us. We thank you very much for your willingness to participate in this session. I wish all of you well until we meet each other again physically, hopefully sooner rather than later. So once again, thank you very much. And I now bring this session to a close. See you next time. Bye-bye.
See you.
Bye-bye.
Can we take picture before?
Oh, yes. So let's all turn on our cams
Sure.
and get a
The
picture.
organizing, please.
We will take a picture for you. Should be okay. Okay. Okay.
You got it. Thank you.
Okay.
Thank you very
All
much.
right.
Thank you very
Thank
much.
you.
Thank you very much.
See you all.
Take care, everyone.
Bye-bye.
See you
See
all.
ya.
Take care.
See you
Bye-bye.
all.
Take care.
Bye-bye.
Bye-bye.
Bye-bye.